Yeni linki de gönderdim ama Tolga'ya. Nasıl?
Bunlar kendilerini tanısınlar.
Amerikan ekibi bağlanınca başlayacağız arkadaşlar.
Var mı? Anlatım var mı? Konferans.
Direkt yok. Bakar. Case.
Şuraya tutarsak onları görebiliyoruz.
Önce bizim buradaki ekibi tartıştırıp son anlardan etkilenmişsiniz.
Tamam.
Görüşme fikirlerini söylesinler. Ondan sonra siz de düşünüyorsunuz.
Ne olmuyor? Demek çalışmıyor. Şuraya gelin. Tamam.
Sen de onu.
Çalışmıyor. Olsun.
Yok o zaman çık.
Siz katılımcılara baş toplanmak diyor.
Geldi hocam.
Yabancılar
24
olan mı?
kişi, 24 kişi var.
Niye getirmiyor?
Şey yapmış.
Şöyle olsun.
Herkes.
User kim user? İslam mı user?
Bağlanamadılar değil mi abi?
Görmedim ben. Buradan gözükmüyor.
Bir bakayım Tolga'ya bir mesaj atayım. Ben bağlayayım diyor Tolga.
Bağlı. Evet.
Niye ekranı
Bir
alamıyorsun?
arkadaşı bağlama ekranı al.
YouTube'da mı? Video yok.
Geldi.
Yani.
Geldi.
Merhaba,
Merhaba Tolga, iyi akşamlar.
İyi akşamlar.
iyi akşamlar size.
İyi akşamlar.
Bu diğer arkadaşımız katıldı mı Tolga?
Ben buradan göremiyorum ama belki oradan görebilir tekniker arkadaşlar.
Daha katılmamış, onu bir uyar istersen sen.
Ben onu bir arayayım.
Tamam.
Bu saatte ne yapılıyor Tolga orada? Genelde hasta bakımı yok herhalde. Öğlen tatili mi?
Tabii hocam, normalde benim bugün ameliyat günümdü. Ben biraz boşalttım. Gautami'nin de klinik günü, o da boşaltmıştı. Poliklinik arasında katılacaktı o da. Ben bir arayayım onu. Beraber değiliz, aynı hastanede değiliz onunla şu an.
Bu arada isterseniz hocam siz tanıtın katılımcıları. Gerçekten tanıyor. Hadi
Sen
işte.
belki açılışını
Ben-
yap. Bir host olarak evet.
Evet, burada ev sahibi olarak tabii görev benim. Öncelikle İmag'ın bu çok değerli toplantılarından birine ev sahipliği yapmış olmanın da mutluluğu içindeyiz. Eski evim. 39. olgu toplantısını burada yapıyoruz. Bu bizim için büyük bir onur. Onun için her iki yanımda olan değerli hocalarım, sevgili abim Mahmut Müslümanoğlu, hocam Vahit Özmen'e birlikte bu oturumu modere ediyor olacağız. Ve tabii ki çok değerli tartışmacılarımız var. Mahmut hocam veya artık ben mi?
Siz tabii ki.
Peki, o gruba ait olsun. Peki. O zaman yine çok değerli hocalarım Profesör Doktor Adnan Aydıner, Profesör Doktor Cihan Uras, Profesör Doktor Zerrin Calay, Profesör Doktor Nuran Beşe, Profesör Doktor Bahadır Güllüoğlu, Profesör Doktor Ravza Yılmaz ve Profesör Doktor Buğra Tuncer hocalarımızı panelde görmekten de çok büyük mutluluk duyuyoruz. Her branşı temsil ediyorlar. Ama aynı zamanda tabii ki bizim için yine bir büyük gurur vesilesi. Massachusetts General Hospital grubundan uluslararası bağlantılarımız da olacak. Vakalarımızı birlikte tartışacağız. Bu bizim için de büyük mutluluk. Doktor Tolga Özmen genel cerrahi branşından ve Doktor Gautami Rao da medikal onkolojiden bizimle birlikte vakaları tartışıyor olacaklar. Heyecanla da bekliyoruz hocam. Sizlerden de bir iki cümle alabilirsem çok mutlu olacağım.
Evet Vahit abi isterseniz.
Bu İmag açılımı olarak İstanbul Meme Araştırma Grubu. Tolga katıldı mı yabancı arkadaşımız?
Birazdan bağlanıyor. Şimdi aradım
Sesin
kendisini.
kapalı galiba.
Şimdi aradım kendisini. Birazdan bağlanıyor. Biraz klinikte işler uzamış, bağlanıyor.
Tamam. İstanbul Meme Araştırma Grubu, İstanbul Tıp Meme Cerrahisi ile Onkoloji Enstitüsü'nün birlikte oluşturduğu bir çalışma grubu. Bu çalışma grubunun bugün 39 mu oldu Muhammed? 39. toplantısını gerçekleştiriyoruz. Ve çok değerli, demin Yeşim Hocam'ın belirttiği gibi tartışmacı hocalarımız var. Ben de bu kurumda olmaktan büyük mutluluk duyuyorum. Çok sevdiğim dostlarım, arkadaşlarım burada. Ev sahipliği için teşekkür ediyorum. Umuyorum ki konularda, olgularda çok iyi seçilmiş, güzel bir toplantıyı birlikte gerçekleştireceğiz. Mahmut, seni dinleyelim.
Tabii yani her kurum kendi içinde konsey yapıyor ama farklı görüşleri bir arada belki ortak dili yakalamak açısından böyle toplantıların birlikte bir takım bilgileri paylaşmanın çok önemli olduğunu inanıyorum. Hani yurt dışı, yurt içi değişik yerlere bağlanarak bu toplantıları yapmayı istiyoruz. Kendi içimizde kapalı kalmayalım istiyoruz. O yüzden çok değerli arkadaşlarımız var. Umarım hem hastalarımız için hem de tabii dinleyiciler için fikir açıcı, herkesin evet demedi. Yani bir kere kılavuz dışı bireysel tecrübemizi de buraya katarak nasıl bireysel olarak bu hastayı nasıl tedavi ederiz ona karar vermek açısından hep beraber umarım güzel bir tartışma olur. ...15 geçe olmazsa başlayalım var.
Tabii.
O da katılırız.
5 dakika arkadaşımız katılırsa İngilizce olarak devam edebiliriz Tolga. Ama biz şimdi Türkçe olarak da başlayabiliriz. Ondan sonra gerekirse.
Slaytlarımız İngilizce zaten Tolga. Oradan
Slaytlar
da
İngilizce.
Tamamdır.
Doktor Berke Bey bu akşam sunacak. Bizim 4. yıl asistanımız. Az kaldı uzmanlığına. Çok teşekkür ediyoruz kendisine de. Tolga, istersen
3 dakika daha bekleyelim.
bekleyelim.
9:15'te başlarız. 19:15'te.
Üç dört vakamız var. Dolayısıyla komentler öz olursa tabii seviniriz. Birçok konuyu tartışma fırsatı yakalarız.
Hocam kayıt herhalde yapılıyor. Sonra
Yapılacak.
yayınlanacak
Evet,
değil mi?
evet.
Onu da netleştirmiş olalım.
Bu konuda Recai Bey ile Erkan Bey'e de çok teşekkür ediyoruz. Böyle bir alt
Teknik
bize
ekip
sağladılar.
olarak.
Teknik ekip olarak evet.
Erkan bizim klinikte büyüdü. Babası bizim slaytlarımızı hazırlardı. Belki Can bilir, eskiler bilir de eskiden fotoğraf çekilip oradan slayt yapılırdı ve slayt klasörü vardı böyle. Bazen slaytlar dökülür, döner.
Tabii.
Biz
Ben
onları
biliyorum.
biliyoruz. Siyah beyaz olurdu da mavi yapmak için çok uğraşırdı yazıları. Mavi beyaz olsun diye Nevzat Bey babası çok emek verdi bize. Öyle yetiştik Çapa'da sıkıntılı günler içerisinde. Erkan görevi aldı. Babasını da aratmıyor. Asıl meslekleri fotoğrafçılık aslında. Evet.
Bu arada bayağı güzel.
Evet. Karuseller oluyor.
Yuvarlak
Yuvarlakları vardı uzun.
Ama sonra
Vardır, sen hatırlıyor musun? Sen o...
konuşmaya başlarsınız hocam bir bakarsınız terstir slaytlar. Hepsi birden ters. Tekrar düzeltiyorum. Tabii bakıp çeviririz. 90 derece. Ters ve 90.
Buraya gelinceye kadar neler çektik hakikaten. Çok hızlı bir değişim oldu.
Çok.
Bilim de çok değişti. Kaynaklara ulaşım kolaylaştı.
O günleri de dokümante etseydik aslında güzel bir tarih olurdu ama
Evet.
bizlerin hafızasıyla bitecek galiba.
Öğrenciliğimizde rahmetli hocalarımızın çok büyük bir şeyi vardı, sopası vardı. Cerrahpaşa'da da vardı eminim. Çapa'da
Tabii
tepedeki tavandaki şeye sopayla gösterilirdi.
Tabii.
İşareti, pointer yoktu tabii.
Bizim Nihat Gürkan hocamız vardı. O da hep bir kauçuk frenler vardı bize. Onun cebinde taşı uyuyanın suratına doğru böyle derste amfikti. Uyuma diye. Evet. Tolga sanıyorum daha gelmedi arkadaşımız.
Evet hocam. Yani
Medikal
poliklinikte hemen bitirip çıkıyorum diye söyledi ama sanırım Mahmut hocam yanlış hatırlamıyorsam plastik cerrahi vakamız da var. Belki onunla başlarız isterseniz. Ya da diğer vakalarla başlayalım. O da katılabildiği yerden
Başlayalım,
katılır.
ona da soru sorarız gerekirse geldiğinde.
Aynen öyle yapalım hocam.
4'le başlayalım hocam. Plastik cerrahi.
Plastik kaçtı? 2 miydi belki?
4.
2 olması lazım.
2 olması lazım abi. 2. Orada burada öyle de orada değişti sıra. Evet.
2. Başlıyorum hocam o zaman.
Buyurun.
Herkese merhabalar. İlk hastamız 40 yaşında premenopozal kadın hasta. Bize sol memede ele gelen kitle şikayetiyle başvurdu. Kendisinin kuzeninde bir meme SEA öyküsü vardı. 25 yaşında tanı almış. 5. senesinde takibinin. Bu hastanın mamografisi sol alt kadranda 1 santim bir heterojen bir alan görünüyor. Yine sol aksilada da 16 milimlik asimetrik lenf nodları, korteks kalınlaşmış lenf nodları görülmüş. Melografisi.
Hocam radyolog.
Abi buradaki tartışma konusu
Daha çok
başka bir şey olduğu için evet onun için hani bunları hızlı geçiyoruz.
MR'ını açıyorum. Hastaya daha sonra çekilen MR'da sol retroareoler alanda areolayı da tutan, duktal infiltrasyonla daha üst dış kadrona doğru yayılım gösteren bir kitlesel lezyon alanı görünüyor. Durdurayım şöyle.
Teknikteki arkadaşlar acaba ışığı ön taraf kapatmak mümkün mü? Ekrana çok yansıyor.
Ravza belki özet yapabilir bize. Ravza hani bu multisentrik bir tümör meme başı ile ilgili ne düşünüyorsun? Karşı memenin görüntüsü rahat mı, nasıl? Mikrofon şeyde var Ravza.
Şimdi sol memede multisentrik görünümlü iç kadranda, dış kadranda, meme başına uzanan, meme başı areolar komplekste retraksiyon ve kalınlaşmayla devam eden malin görüntüleme özelliklerine sahip kitle lezyonu görüyoruz. Karşı memede kuşkulu kitlesel bir kontrastlanma izlemedim. Aksilla da yeterince görüntü alanına girmemiş bu kontrastlı görüntülerde. Onlar için de bir şey söyleyemedim şimdi. Ama meme başı invazyonu olan multisentrik malin kitle.
Evet, devam edelim istersen belki.
Tabii hocam. Hasta aynı zamanda çekilen PET'te de yine retroareoler alanda 5x2 santim boyutunda yine toraks duvarına doğru da uzanan FDG tutulum gösteren bir kitle saptanıyor. Yine 2 adet de milimetrik yine toraks duvarına komşu FDG tutulumu olan 2 adet daha nodüler lezyon görülüyor. Aksiyada da yaklaşık onda şöyle geliyordu. Aksiyada da yaklaşık 5-6 adet patolojik lenf nodu görünüyor yine. FDG tutulumu olan. Şimdi hastamız multisentrik meme başı invazyonu şüphesi de var. Kitleden alınan biyopsi invaziv duktal karsinom olarak geliyor. Grade 2 olarak. Yine aksilladan da bir ince iğne aspirasyon biyopsisi yapılıyor. Bu da karsinom metastazı geliyor. Burada çalışılan reseptörlerde de östrojen %80, progesteron %75, her iki 3 pozitif. apsisi %20 olarak geliyor. Burada cerrahi düşüncemiz nedir? Neoadjuvant kemoterapi yapılırsa cerrahimizi etkiler mi? Bunları tartışmak istiyorduk.
Yani bu vakıda böyle bir vakaya neoadjuvana göndereceksek buradan öncesinde tedaviyi belirlemiş oluyor muyuz? Nasıl davranırız? Bu konuda görüşlerinizi alalım. Bir cerrah olarak Cihan Hocam senden başlayalım istersen.
Şimdi multisentrik bir tümör ve başında çekmiş bir tümör ama tabii ki her iki üç pozitif neoadjuvant kemoterapiye ve antibiyotik tedaviye iyi cevap verebilir. Ve burada cerrahi kararım yine de yani bir koruyucu cerrahi olmazdı. Çünkü demin Razan'ın gösterdiği gibi iç kadranlarda, dış kadranlarda ve baş arkasında yaygın olarak tümör olanlar vardı. Patolojik cevapları olabilir. Ama burada yani o zaman şuna gideriz. Tam patolojik cevaplar hiçbir şey yapmamaya gider. Yani cerrahi yapmamaya gider. Cerrahi yapacaksak da buna bir nipple sparing veya skin sparing mastektomi tercih ederdim. Başta da kararım olurdu. Dolayısıyla herhangi bir yer işaret etmeye de gerek yoktu. Meme başı için şu anki haline baktığımızda sanki skin sparing ile gider gibi görünüyordu. Ama eğer tam cevap alınırsa ve yaptığımız ameliyatlarda o meme başı çekilmesi falan bazen gerçekten çok iyi düzeliyor. Hiç tümör yokmuş gibi hale geliyor hasta. Meme başın arkasına tekrar biyopsi yapıp yani hasta da çok korunmasını istiyorsa o zaman meme başı korunabilirdi. Aksiller cerrahi değişmezdi. Yani şu an tabii ki başta olsa belki küraj gibi görünürdü ama herhalde iyi bir cevap verdiği takdirde de buna SLN ile gidip SLN'de eğer negatifse SLN ile yetinirdim bu hastada.
Bahadır sen ne yapardın?
Ben de çok farklı bir şey yapmazdım. Yani sonuçta burada
Yani bu
multisentrik ve geniş bir alan.
sonra cerrahi sonucu neoadjuvant sonrası karar verilir yoksa şu anda buna karar verilmiş olur mu?
Şöyle söyleyeyim, sonuçta burada meme içerisinde yaygın bir tümör olduğu için özellikle de hani tek bir tümörün meme başının tutulmasıyla onun dışında 2 tane satelitinin olması arasında biraz fark var. Tabii burada yine ben baştan mastektomiyi ben de düşünürdüm. Meme başının korunup korunmaması cevaba bağlı olarak sona bırakırdım. Ama aksiller için de dediğim gibi baştan neoadjuvant tedavi sonrasındaki yanıtına göre sentinel nodu biyopsisiyle devam etmeyeceğimizde yanıta göre en sonunda karar verirdik. Yani eğer memeyi soruyorsak mastektomi.
Tolga sen ne yapıyorsun orada? Nasıl davranıyorsun?
Hocam ben de katılıyorum hocalarımın görüşlerine. Hastanın görüşü de önemli bu konuda. Hasta eğer meme koruyucu cerrahide ısrar ediyorsa kemoterapi sonrasında o bölgenin vakum biyopsiyle diğer alanların da biyopsilenmesi sonucunda belki meme koruyucu cerrahi de denenebilir. Hastanın 40 yaşında olması, genç yaşta olması, rekürrens riskinin artması açısından önemli bir faktör. Üç ihtimalle göz önünde bulundurulabilir ve daha sonra MRI ile memenin tekrar stage edilmesi tartışmayı yönlendirmeli diye düşünüyorum.
Neoadjuvant sonrası vakum yapıyor musunuz? Öyle birkaç yerden de öyle koruyucuda kalabiliyor musunuz? Yoksa başında bu yaygın bir karar oluşuyor mu?
Var hocam. Bu sabahleyin de bu konuda Kelly Hunt gelip konuşmuştu. MD Anderson'ın kendi deneyimlerini anlattılar. Bunu çok güzel standartize etmişler. PCR, klinik olarak PCR elde edilen hastalarda birden fazla o alanın detaylı bir şekilde biyopsilenmesi, hepsinin negatif gelmesi durumunda acaba cerrahi yapmasak mı bile gündemde. O görüntülemek çok önemli.
O zaman birkaç alana klip koyulacak. O alanlar biyopsi verecek sonrasında.
Aynen hocam. Klibi vakum biyopsiyle alıp yeni klip koymak da prosedürün parçalarından biri. O klibin de ikinci kez biyopsilenmesinde spesmene dahil edilmesi, tekrar o bölgenin kliplendirilmesi, hiçbir canlı kanser hücresi görülmemesi durumunda acaba ameliyat yapılmaması o nümeye.
Peki böyle 5-6 lenf nodu tutulumu hastalarda cevaba göre sentinel nod mu yoksa küraj mı? Nasıl bir tavrınız var?
5-6 lenf nodu gerçekten de ciddi bir tümör yükü aksillada. Çok sentinel lenf nodu özellikle kliplinin çıkarılması, yani sentinel yine yapılabilir. Görüntülemede şüpheli lenf nodu kalmadığı durumda 2 tane boyanın kullanılması, radyoaktif ve blue dye'in ve en azından 2-3 lenf nodu çıkarılması, kliplinin çıkarılması başarı şansını artırmakta yapılabilir.
Meme başı için ne yapardım bu vakada?
Hocam mutlaka frozen gönderiyoruz biz de. Mutlaka ameliyat sırasında spesmenden frozen göndermek lazım. Eğer pozitif düşünüyorsak sadece memenin etrafından bir insüzyonla nipple'ı alarak skin sparing şeklinde yapılabilir. Daha sonra da plastik cerrahide yeniden meme başı yapılabilir oraya. Çok güzel sonuçlar elde edilmekte. Sadece meme başında tutulum varsa yine de skin sparing ile sadece meme başının ve meme dokusunun çıkarılması uygulanabilir ya. Çok güzel sonuçlar elde edilmekte.
Yani biz şöyle diyebilir miyiz o zaman? Böyle direkt görüntüde meme başı tutulumu olduğu zaman sonrasında bu mutlaka alınması gerekir diye bir şey değil ama bunu check edelim. Ona göre koruma yoluna da gidelim diye bir konsensüse varabiliriz.
Kesinlikle hocam.
Tam cevap halinde. Baydar bir katkınız olacak mı abi?
Şimdi tabii bu MD Anderson'da Harry Kurer'in ortaya attığı bir hipotez bu. Acaba tam meme kanseri cerrahisinden vazgeçebilir miyiz diye. Bununla ilgili kendi serilerinde vakum biyopsinin negatifliğinin sonra çıkarılan spesmenle karşılaştırıldığı durumlarda yanlış negatiflik oranı tam yanıt açısından düşük gösterilmiş, %5 civarında, ama daha sonra yapılan bazı çalışmalarda yanlış negatiflik, yani vakum biyopsinin negatif olduğu ancak eksize edilen spesmenin pozitif olduğu oranlar %29-30'a ulaştığı için bu tartışılan bir konu. Bu nedenle tabii Kelly Hunt da şimdi orada memenin başında, o da onunla aynı grupta olduğu için onu savunuyordur diye düşünüyorum, ama ben henüz cerrahinin meme kanseri tedavisinde olmaması gerektiğine inanmıyorum şahsen. Çünkü çok farklı şekilde tümöre yanıt olabiliyor. Çok dağınık şekilde tümör hücreleri canlılığını pelik dışında sürdürebiliyor. Bu hasta için düşünürsek, bu hastada tedavi sonucu gerçi triple pozitif ama tam yanıt olasılığı fazla. Belki doğal Herceptin ve pertuzumab kullanılacaktır. Yine de meme başının korunmasının bir risk olabileceğini düşünüyorum, ama bu hasta gene gerçi radyoterapi alacak, onu Yeşil Nuran Hoca'ya soracağım. Nuran.
Sormak
Buyurun
istiyorum
hocam.
hocam, izin verirseniz.
Estağfurullah, buyurun.
Aslında Adnan Hoca'ya bir soruyu da yöneltmek istiyorum. Çünkü şu andaki hani pratiğimizi ve standartlarımızı düşünecek olursak tabii çok hakikaten ilgi çekici bir konu bu. Biyopsilerle negatif bulduğumuzdan cerrahisiz bir opsiyon mümkün olabilir mi diye, özellikle de tam yanıt olasılığı yüksek olan her iki pozitif hastalık için çok iyi bir şey. Ama şu andaki pratiğimizi göz önüne aldığımızda Adnan abi, sizin görüşünüzde böyle bir yöne doğru gitmemiz kolay mı? Çünkü rezidüel hastalık milimetrik bile olsa şu anda elimizde bazı veriler var. Bu konudaki düşünceleriniz nedir?
Yani cerrahisiz bir şu an için mevcut tedavilerimizde mevcut çalışmıyor herhalde.
Çalıştı. Şimdi o.
Mevcut tedavi yöntemleriyle, elimizdeki tedavi yöntemleriyle şu anda bu tip vakalarda cerrahisiz bir tedavi seçeneği çok uygun değil bence. İleride belki çok daha etkili sistemik tedaviler bulursak, yani %95, %100'e yakın tam yanıt aldığımız tedaviler eğer ileride geliştirilirse tabii o zaman durum farklı olur. Yani lenfoma gibi mesela örnek olarak bir yanıt tablosunda çok yüksek yanıt oranlarında o zaman cerrahiden vazgeçilebilir. Ama şu anda halen bizim tam yanıt oranlarımız %60-70'lerde, yani %35 civarında yanıt alamıyoruz. Ki böyle bir hastada hormon pozitif bir hasta bu patchy yanıt verecek. Yani özellikle bu vaka içinde bu çok daha riskli tabii olur.
Ama bence Kelly serisi güzel. Orada triple negatif ve B2 pozitifler var. 40 kadar vaka var ve 40 negatif vakada 3-4 yıllık takipte hiç lüks yok. Yani aslında buna karşı çıkmamak lazım.
Çok
güzel örneklersek
evet,
niye olmasın diye.
yanıt o yüksek
kapıyı
olduğu
açık
için
bırakalım.
orada triple
That
negatif.
so I would like to take this opportunity to welcome our guest panelist, Professor Gautami Rao.
who's a medical oncologist from Massachusetts General Hospital. Welcome to our panel, Dr. Rao.
Thank you. Thank you for those kind words.
Okay, so we were discussing about a case whom we thought maybe a surgical treatment would not be required based on a high anticipated high response rate of HER2-based therapy. So what is your opinion on therapies where, where we expect a high response rate and then we could omit surgery? Is that possible?
Not a standard of care. I think, unfortunately, breast cancer, unless the person cannot go through surgery for some reason, I still think it's a surgical disease. You might be able to hold off for some time, but the risk, I think the tumor or the tumor bed has to be resected. And that's what I would strongly favor. Is there a reason the person cannot go through surgery?
Excuse me, did you?
Can the person not have surgery? Is there a reason why they cannot?
No, Dr. Rao, this was a general question, my understanding. Generally,
no,
talking about the MD Anderson study, Dr. Kurer's study, when there's a perfect response, no visible tumor in the breast, whether to watch that patient, like we do in rectal cancer, esophageal cancer.
I think you can definitely argue for watching it, but I'm not sure that you caught me off a little off guard. So I still feel strongly that in practical practice here, we still think it's a surgical disease. I mean, we do not, if we have to delay surgery, yes, if we have to monitor because of issues, they've had a blood clot and they cannot have surgery for 6 months, okay. If they are in their 80s or 90s and you feel they have other comorbidities and you want to hold off treatment, I feel so. But practically, I think at this point, anyway, the way we are dealing with it is still it's a surgical disease.
Okay, we can continue.
Yes. Thank you.
Yes, about this patient, should we perform genetic testing, keeping in mind that she has 2 kids, one 14-year-old girl and one 16-year-old boy? And will the result affect our surgical technique?
This question is, do you advise anything more, Grubu?
Me? Are you asking me?
Yes.
No, the question goes to
Grubu.
Professor Tuncer and then probably to our surgeon colleagues.
Genetics.
Genetics.
Genetic test.
I advise
Yes.
the genetic testing is her cousin, I think, is
Yeah, her cousin is
breast cancer,
early age.
early age. We can do the genetic test for her children.
The question is it change your surgical decision? I may ask Bahadur, is it change your surgical decision for contralateral breast and?
Well, it's, well, certainly it may change because, we have a case who is 40 years old with a family history and, probably she will be receiving a neoadjuvant chemotherapy. So we still have time to make this genetic testing, but we have to discuss this with the patient as well, because for now, what we know is that when you do a surgery, bilateral, prophylactic, or risk-reducing mastectomy only, there's no high evidence, showing us that the mortality is decreased. But in fact, we know that the risk of having a contralateral cancer in these patients is really high, especially when we have a genetic mutation in BRCA1 and BRCA2. So this should be discussed with the patient but everything should be on the table saying that, because there could be, complications or other certain, things which may happen to the patient. And, the patient may regret having a bilateral surgery at the end. So, because sometimes patients are preferring that, okay, I want to live with my breast on the other side because I'm 40 years old and I still have time. But on the other hand, because they have the anxiety to have a second cancer, so they would prefer to have a contralateral mastectomy in a risk-reducing matter. So this should be on the table, discussed with the patient, but still we have time because there's still time, like, 46 months, 4 to 6 months to have an, opinion at the end. And then we may go forward after a shared decision-making. So yes, definitely we need a genetic testing here.
Cihan Hocam, do you agree with him?
Yes, I agree. And genetic tests affected my surgical decision. But this lady has a locally advanced breast cancer. Contralateral prophylactic mastectomy doesn't affect her survival. Survival is the same. Contralateral mastectomy doesn't affect. And then I discussed with the patients about the subject. If the patient wants to keep another breast, okay, no problem. It depends on the patient's decision.
If we put on the table how the patient can decide this very difficult question. I mean, there is no survival advantage, nothing. She will receive many chemotherapies and radiation therapy. So immediately does she need this surgery? Contralateral surgery.
But I discussed it with the patients. Some patient doesn't want to keep another breast. I discussed a lot of time this subject because it is very important to keep the breast, especially filling is very important for the woman. And yesterday I discussed with the patients about this subject. The patient wants to keep another breast, especially, for example, the very early breast cancer, and also has the family history about the breast cancer. And in this situation, I advised the bilateral mastectomy. But locally advanced breast cancer.
In this case, it is not important to do prophylactic mastectomy. Okay, any opinion of Olga? What would you say?
So every breast cancer patient younger than 50 years of age, we go with genetic testing per NCCN guidelines, and up to 65 years of age with triple negative breast cancers. So saying that the patient needs the genetic testing now, if the patient comes back as genetically mutated, let's start with the BRCA1 and 2. As Dr. Dilloğlu said and Dr. Uras said, there is no survival advantage at all. Either the patient receives prophylactic mastectomy, either the patient receives total mastectomy versus breast conserving surgery in BRCA positive patients. Now, the vast majority of the literature is showing that there is increased risk of recurrence, local regional recurrence, if you go with the breast conserving surgery, about 1.5 increased risk with breast conserving surgery, but even still, survival is the same. And lately, there was a study from Memorial Sloan Kettering saying that actually even the local regional recurrence is the same if the patient has BRCA mutation or not. So that's a discussion that needs to be made, first of all. Second of all, contralateral breast cancer, it depends mostly on patient's preferences and also patient's age. Now with BRCA1, there's about 40% risk of developing contralateral breast cancer. This risk is a little less, about 20–25% with BRCA2, but there's a risk if the patient wants to deal with this risk or not. Now, after 50–60 years of age, this goes down to 20%. So this is another discussion that needs to be made. Lastly, BRCA1 and 2 are not the only genes. This patient, depending also on the family history, obviously, can come up with a TP53 mutation, which makes the patient ineligible for radiation therapy. So genetic testing is very important and needs to be done.
Okay.
May I add something?
I have another idea about this patient. If this patient has a BRCA-positive breast cancer, I think this patient should require contralateral prophylactic mastectomy, because we don't know if the patient will have any kind of triple negative breast cancer. If the patient has a triple negative breast cancer in other breast, that this prognosis of this cancer is worse than previous cancer. So I strongly recommend contralateral prophylactic mastectomy for these women. Probably these women will be cured after this neoadjuvant chemotherapy surgery and also radiation therapy. I think radiation therapy also requires for this patient. To me, I should do prophylactic mastectomy for the other breast if the patient has a BRCA1/2 positivity.
I can say something else and contrary to you. If you look at the holistic approach, she has no problem at the right breast. She has the only cancer, close family in the only cancer, and she will receive chemotherapy, hormonal therapy, and these therapies modify the BRCA1 or 2 mutation carriers risk. So up to 10 years, the risk is becoming the sporadic cancer. So in this case, I don't advise anything more for the right breast.
I think nobody wants to get a second time systemic chemotherapy if she has a systemic chemotherapy before. So I strongly recommend mastectomy, prophylactic mastectomy for other breasts. If you ask any patients, she had breast cancer before, nobody wants to get the second time systemic chemotherapy. If this patient has a triple negative breast cancer in other breast, it's very difficult for his future, for her future. So I don't want to have it the same.
Advanced breast cancer, this cancer will be the prognosis will be.
Now, I will ask Dr. Gotami, what's your opinion about this patient? This is a different topic.
Yeah, well, no, actually, this is something we deal with a lot because the one good news is you're going to give her neoadjuvant therapy, so there's time for her to decide. And psychologically, emotionally, they go through so much. You know, at 40, if she's done with childbearing and she doesn't really want to worry about being able to breastfeed in the future, I can tell you, I would say there most women hate the process of having to get another mammogram or an MRI and wait for the results and be told you have to get another biopsy, you know, year from now, 2 years from now. So I would say the conversation needs to be had. I don't think you're correct. I don't think there's either is wrong. The most important point is that the current breast cancer is going to dictate her prognosis because it is a fairly big, aggressive tumor. And if she's going to die of metastatic breast cancer, it's going to be this cancer and not a second potential future cancer. But that being said that, she's in the prime of her life. She has young children. She needs to take care of them. So it really depends on her emotional well-being. If for her, she says, you know, I really don't want to lose any more body parts and I'm willing to put up with screening and MRIs, then I think you know, mastectomy and reconstruction on this side, most likely, she'll have a very good response to neoadjuvant therapy is acceptable. But I can tell you 2 out of 3 women who don't have to worry about childbearing again, will probably say, take away the breast, give me, you know, reconstruction. So I don't have to worry about this in the future. So I think the conversation has to be had with her. And I can tell you more often than not, they mostly elect to have bilateral mastectomies and reconstruction. But I still think her prognosis is going to be driven by this current cancer. And yes, she does remain at risk for a potential triple negative and another breast cancer. We are going to try and give her anti-HER2 therapy, maybe PARP inhibitors, whatever it is, if she's BRCA positive, to push off that second malignancy. But I think it's her emotional status that needs to be addressed at this point. I don't think either answer is wrong, but I can tell you most people will want bilateral mastectomies.
I think Bahadur has comments.
Well, we shouldn't forget 2 things here because we're always talking about risk-reducing mastectomy, but there's another issue. You're making a test, and when you have a positive, you know, mutation in these patients, you have to think about the risk-reducing bilateral oophorectomy, because that's the most important thing here, which reduces the mortality in these patients. So without this, just, asking for a bilateral risk-reducing mastectomy, in this case, I don't think that it will give a benefit to this patient, unless in one condition, because we still have 4 to 6 months to see the response to the neoadjuvant chemotherapy. That's why I said in the beginning, if you have an exceptional response to the anti-HER2 treatment and everything vanished, then maybe there would be a marginal benefit to have a contralateral mastectomy, but only in addition to bilateral self-injure oophorectomy. So this is not written anywhere. This is not a proven thing, but that is why, you should think when you're doing your, your practice, because we know that from many studies, when you have a complete response to the neoadjuvant chemotherapy or the neoadjuvant systemic treatment, then you have an equal survival like you have a luminal A or luminal B tumor. So maybe that's the only case where you can see rationally a way to go to risk-reducing bilateral mastectomy, but only with just supposedly marginal benefits.
So we can say if the complete response achieved, bilateral surgery can be.
Maybe, yeah, you may, you can put it on the table. But also, question here, you're making a genetic test and you find a positive mutation. What if you don't find a positive mutation in this patient? So that's the case.
Yeah.
So the usual practice here is we wait till they're 45 before we do the bilateral oophorectomies, because we don't want to put them into really very, very primitive. They are going to go into menopause with the chemotherapy, yes, but you worry about bone health. And so we wait until they are 45 at least before we recommend the bilateral oophorectomies. We don't do it at 40 if we can avoid it.
Okay.
Within maybe 4 or 5 years to do bilateral oophorectomy.
Okay, we can carry on.
Yes, about this patient, should we consider neoadjuvant chemotherapy? Which chemotherapy regime will be the best, and is de-escalation is possible?
Okay, I'd like to direct these questions to, first of all, to Professor Aydener, and then to Professor Rao for their opinions.
In these patients, we generally recommend combined anti-HER2 therapy with chemotherapy as an neoadjuvant treatment. We generally don't give endocrine treatment during this treatment, generally.
Which regimen would you suggest?
We generally give trastuzumab, pertuzumab, and Taxan regime.
What about anthracyclines?
Yeah, first in our institute, we give 4 courses of 4 AC, then trastuzumab, pertuzumab, and taxane regime.
Okay, so Dr. Rao, are you a believer in anthracyclines as well?
Well, when she's so HER2 positive and estrogen receptor is positive, in her, we would probably pick taxotere, carbo, Herceptin, and pertuzumab. And then based on the response afterwards, we would give adjuvant Herceptin and pertuzumab for 9 months if she's had a complete pathologic response. Or if not, then we would give TDM1 based on the Catherine study. So we have been switching to TCHP and avoiding anthracycline, especially in a 40-year-old, and the Herceptin and the pertuzumab. But if, say, clinically she doesn't respond halfway, you reevaluate with an ultrasound after 3 cycles, and she's really not had any response, which we do see that happen, then I will reconsider anthracyclines at that point. But the first choice for us would be taxotere, carbo, Herceptin, and pertuzumab.
Would you add endocrine therapy to that regimen with the chemo?
No, not neoadjuvant, and no, because she's probably still going to need tamoxifen after. We would wait until after all the neoadjuvant therapy is done. And if you're going to add tamoxifen, we'd add it after radiation with the Herceptin or the TDM1.
No, I was actually inquiring about LHRH MLOs.
Oh, yes, good point. I would probably consider, if, again, it depends on the data is not strong. So do you want to preserve ovarian function? You could consider giving her Lupron or a GnRH analog, and that would be fine. I think it would help, not
Right.
symptom-wise, but yes, it would be something we would talk about.
I think Professor Aydiner has a
Now,
comment.
Taxotere, carboplatin, and anti-HER2 treatment, I think, is the recommended first option in NCCN guideline. But in our practical patients, the toxicity is very high. So I don't know. What about, for example, Yeşim, what do you think about that? It has very high toxicity. So in Turkey, it is very difficult to give this treatment to our patients. So we recommend the old regimen as for AC, then
The classic one. So I would like to direct the question to our guests here, the floor. How many of you still use anthracyclines as part of the standard regimen in HER2 positive disease? First of all, I want to see medical oncologists. Handan Abla, I know you're there. Meltem, I know you're there. And you're both using anthracyclines, is that so? For all patients? Okay, so Professor Rao, I don't know if you've seen the floor here, but every one of us, and not every one of us, I'm not the person, I generally tend to omit the anthracyclines as opposed to my.
Toxicity?
Yes, definitely. What I do is that I start with the TCHP, like the BCRG regimen, and then I continue following the patient every 3 weeks. If it's too toxic, I switch to a weekly regimen, which is not too toxic, actually. And then after like 6 to 9 weeks, if there's a major response, I go forward with the same treatment. Of course, the patient's receptor status makes a difference, to my belief. If she's receptor positive, I really tend to go with the TCHP. If negative, I would consider switching to AC after 9 to 12 weeks based on the response that we get from the dual treatment. So that's what I do in my practice.
So yes, you can continue.
Yeah, sorry.
Okay.
Okay, thank you.
Yok abi, bitireceğiz bunu.
So this patient received 4 AC for docetaxel, trastuzumab, and pertuzumab, and it showed clinical complete response. And which imaging modality should we use to assess the response to neoadjuvant chemotherapy? And can the response to neoadjuvant chemotherapy change our surgical technique?
Short answers, do you check all the patients, which imaging modality you use, or mandatory in this case?
Are they reliable? I think that's the most important question.
Surgeons or medical oncologists?
No, for
On the radiologist as well.
no, for the surgeon, do you advise some imaging? Yeah. In all cases, for this case also, multicentric, nipple involved.
If I do the breast conserving surgery, and also I like to see the nipple areolar complex situation, I prefer breast MRI. But especially this patient has an axillary lymph node metastasis. I like to see the axillary response. Then I see PET-CT for axillary response.
Exactly.
The same. Ravza, what would you recommend for the response, to evaluate response?
MRI is more accurate imaging method for evaluating the neoadjuvant chemotherapy. But sometimes ultrasonography is more useful, in my opinion, for fibrosis or residual carcinoma in situ. It can be changed for patients.
What is more reliable for the axillary involvement? I mean, ultrasound or PET-CT, MRI, what's your opinion? What is your experience?
Ultrasound is excellent imaging.
Depends on the radiologist's experience.
Actually, it depends on the radiologist.
Exactly.
You can, yeah, backside.
Filiz.
Actually, I agree with my colleague, but I prefer to evaluate this patient with MRI first because we see the disease is multicentric and we know it completely vanished after adjuvant chemotherapy. But it can be much more accurate to evaluate maybe the residual disease. For example, we can see small foci with the PET CT, but it's sure that for the axilla, we need to evaluate with ultrasound. We can use a combined evaluation for this patient. Also, we can use PET CT as well. This is my opinion.
Tolga, what would you do for this patient?
For this patient, the response of the treatment, MRI is superior to other imaging modalities. I would definitely use MRI for surgical planning. Ultrasound axilla, we use it commonly, and also ultrasound intraoperatively if we're planning breast conserving surgery for margins.
Okay, next slide.
Here we can see the CT scan that shows the complete response at the lesion and the axillary lymph nodes.
Then the next question.
About the surgery, should it be skin-sparing mastectomy or nipple-sparing mastectomy with breast implant?
Yes, the question, what would you advise? Yes.
I prefer the nipple-sparing mastectomy, but I take the sample under the nipple areolar complex and some pathologic exception. A pathologist says there's not any problem. This specimen, I preserve the nipple areolar complex because this patient needs to have radiotherapy.
Can we see the breast again? And which type of reconstruction you advise? Prepectoral, retropectoral, or
Yes.
PDM1, ADM?
In generally, we do not prepectoral, under the pectoralis major muscle, and also we use the ADM mesh together. But in this last San Antonio, there was a presentation about this subject. If the patient needs to do radiotherapy, they prefer the prepectoral approach to prevent the capsule contracture.
Yeah, our trend also changed in the last 5 years. So we used to put prepectoral area. Father,
well, I would echo the same, but only one difference maybe, because after the MRI, if you see a complete response here, especially to the nipple areolar complex, because the breast is multicentric, so you will anyway do a mastectomy in this patient. But if you have the courage to do a nipple areolar complex sparing mastectomy, you definitely need a biopsy, a frozen section under the nipple. And if that frozen section says that it is negative, then you may continue to do a nipple sparing mastectomy. But of course, the frozen section is not the permanent result. So you have to wait for the permanent result from the pathologist to say that the operation is complete here. Because it's anyway, if there is an in situ cancer there, you have to remove the nipple. But that's not a difficult operation. We know that, but it is a second operation. So you have to tell this to the patient, so the patient should be prepared for this kind of a second operation. Coming to the implant reconstruction, for the last couple of years, we're doing more and more prepectoral reconstruction, and we're happy with it. Also to those patients who just have the indication for radiation treatment to the chest wall. So up to now, we have very minimal complications in these patients. So we prefer to do prepectoral reconstruction with implants in this type of patient.
So do you have any limit for skin thickness? I mean, when you...
Well, it depends on two things. The first thing is that the preoperative, the mammography, because according to the mammographic appearance, you can see the fat tissue under the skin. So there's Alberto Rancati's classification in mammography. When you see, for example, this is a lady who's 40 years old, so probably there is a very thin tissue, fat tissue beneath the skin.
What is
So
very thin?
I
What
mean,
does it mean? What
it means that when you do a surgery, if you ask me, I can tell you that it depends on the patient, because when you see the breast tissue, you have to remove it. So you have to, it could be very thin, like 2 millimeters or 3 millimeters. But it depends.
5 millimeters okay for the thickness of the skin?
Yeah, it depends on the type of the breast, you know, and then when you see during the operation, it is a fat tissue, of course, but more than 5 millimeters, well, I don't think that would be okay.
Because some people advise 1 centimeter thickness. It is very difficult. Mustafa, what did you advise? Is the thickness of skin for prepectoral silicone implant?
Do you do reconstruction yourself, Mustafa, or invite plastic surgeon? I know in United States always call for plastic surgery to complete the surgery.
We advise them to start.
We perform reconstruction, plastic surgeon or alone. I advise the prepectoral reconstruction of these patients. There are 2 important points. One of them, the skin thickness. The other one is economical situation for these, patients. Important for give money to Toppage or ADM.
Economic reasons.
Olga, what is your opinion? What do you do over there? Which technique you use?
So in academical institutions, plastic surgery does the reconstruction, but as in private practice, breast surgeons do it themselves. When they choose between which technique they're going to use, there are 2 important discussions that needs to be, or paths or ways that you can go. First of all, expander versus DTI, direct to implant. And then the second one, either expander or implant, where are you going to place it, prepectoral or subpectoral? Now we have large series of MGH. We started early in 2000s with nipple sparings after neoadjuvant or so. And according to our results, the complication rates are similar. DTI, direct to implant, is usually preferred in safer patients, to say non-smokers, small breast size, moderate breast size. And then expanders usually are chosen in large breast size patients, in patients who wants to go a larger size, wants to change the size. That's how we usually decide, rather than radiation therapy or not, between expander and direct to implant. Now, prepectoral versus subpectoral, then radiation treatment plays a role, as Dr. Uras was explaining, especially during a couple weeks after the radiation therapy is started. Usually the discomfort with the prepectoral is less. Patients are more comfortable with the prepectoral approach. When the patient is going to undergo unilateral reconstruction, usually we choose prepectoral because the implant sits lower, looks more natural. If the patient is going bilateral, then subpectoral is a good option. If the flap is thin, subpectoral is a good option because the muscle sits on top of the implant. But at the end, if you choose the patient correctly, the complication rates are similar and both can be used.
Thank you. And Duran?
If you are discussing this patient, the thickness is not a matter of debate, because I completely agree with Dr. Özmen. He said at the beginning, this patient is undergoing radiotherapy because NTU disease. We do not have any evidence-based results regarding the radiation of complete response of the patients after neoadjuvant chemotherapy to irradiate or not irradiate. The NSABP D51 trial is going, but it is N1 patient. So this is N2 patients, and these patients needs radiotherapy, and it will receive radiotherapy because there is no trial. And we believe that this, all N2 patients, even they have complete response, will have radiotherapy. Regarding the implant type, the thickness is not important. You discuss this very long, but there is no discuss about the safety. They are going to receive radiotherapy. And if there is a microscopic involvement under the nipple areola complex, again, radiotherapy is going to control it. As we have results from a Milan series, if you irradiate the nipple areola complex, and if there is a tumor there, you control that area. The recurrences come from the other part. So what I advise to the surgeons, they do a biopsy during surgery. If it is negative, just leave the nipple areola complex. If it is positive after the final pathology, then I say that leave it again, because radiotherapy is going to control, so there is no discussion regarding the safety.
If there is no gross involvement. Okay, do you have any opinion which type of surgery contractor is more when you radiate? Prepectoral or retropectoral?
According to studies, we know that if you do one
Your experience.
Okay. First, let me talk about the data. According to data, if you do one-stage implant, the contractor risk is high, but implant loss is less. If you do expander, if you irradiate the expander, contraction rate is less, but implant loss is high. So for these patients, what I recommend, in our center, we are doing one-stage implant. It's mostly subpectoral or combined approach. But what I recommend, I'll recommend doing an expander to these patients, and after that to do a prepectoral implant. Because if you do the expander, then you are doing when you are putting the final implant, you are opening the fibrotic area and it decreases the contraction. Okay, so simply what I recommend, putting the expander and doing the prepectoral implant.
We left expander so many years ago, so we just.
I know, but I know.
And we are happy with prepectoral and radiation.
It's changing. You told me that I'm conventional, but I'm not. That's what you think, because it is going from here to there, so it's changing a little bit.
Okay, we can continue if no comment.
There were some questions here. Actually, would like to maybe
please.
just, would you, okay, allow me? It says that there's one question referring to nipple fluid or
Discharge. Bloody discharge.
Bloody serial hemorrhagic discharge. If the discharge is continuing despite clinical complete response, would that change your surgical plan? Any comments?
So,
well, I would do the same. I mean, I would do the frozen section there, and well, this is not an usual case. I mean, if there is a complete response, you shouldn't, expect a bloody discharge in these patients. But if there is a case, of course, you may continue to do the frozen section, as we heard from the radiation oncology, that whether there's inside the cancer remaining, they would radiate it afterwards anyway. Thank you.
I would ask pathology. It is easy to respond negative margin behind the nipple. Is it easy?
No, it's hard. So I want to cooperate with Nuran. So it's so comfortable. She should radiate. So it's very hard.
Okay.
How about the focal positivity in the surgical margins? Just 1 point.
For nipple area?
Yes, nipple area or the surgical cavity.
For nipple area, it's very hard after neoadjuvant chemotherapy. It's very hard because residual cellular is heterogeneous, so it's difficult. However, for margins in breast conserving surgery, we are good. I can say that.
Okay.
And there are some other questions, and one of them pertains to the local, what is the local recurrence rate after bilateral prophylactic mastectomy in BRCA carriers? I think that was answered by Professor Bahadur in your previous comment. Would you?
Yeah, it's not so different from the regular mastectomies. There's no difference between BRCA1 positive and negatives.
Okay. So another question is,
How about
I
the
wonder,
smoking?
yeah, about the smoking status. If the patient is a heavy smoker, should that change your surgical decision and radiation plan as well?
It is very important point, but I don't change my surgical decision.
Yes, so do I. I mean, we say a little bit high complication rate, but we still
Hey.
continue, yeah.
I say the patient about this problem.
Say the patient continues smoking.
So the next case we can continue. One more case that we can have a time, maybe one more case we can look.
Hocam genetik olan mı her iki pozitif?
Her iki pozitif olan.
Basacağım da doğru da mıyım onu gör. Değil sanki.
Can I ask one more question before we start that?
Yeah.
We talked about nipple positivity. How about skin envelope positivity? Let's say on the superior margin, on the specimen, you do a nipple sparing mastectomy and then there's a positivity, focal positivity. I want to ask this to both the surgeons and the radiation therapists. Are they comfortable with not going back, not converting it to a total mastectomy and just radiating the breast? What would their approach be if there's a positivity in the superior margin, let's say?
This should be first answered by a radiation oncologist, I guess.
Okay, well, actually, although I have a huge experience, I always rely on data. We don't have a data regarding the positive skin positivity and radiotherapy controls it. We have it on nipple areola complex, but not on the skin. So I won't feel comfortable, but I'm increases goes to the area because it changes all the operation and surgeons do not want to change the operation and do something. Re-excision is not possible in these cases. So we just use bolus and increase the dose at that area, but I don't feel comfortable. I discussed the case with my surgeon.
Well, the surgeon's response will be, there's no breast tissue left, I guarantee you, it's just skin. That's the usual response.
Yes.
What we look at the imaging also together with our surgery and the pathology looks also the imagings, and if we think there is lots of tissue, I mean, take a MRI later on. If there is a lot of tissue, you can consider re-excision or other many things to do. Yeah.
You have to do, quick,
Yeah, quick. Yeah, next case.
Our next patient is a 56-year-old postmenopausal woman who came to us with a palpable mass at her left breast. She has a distant family history. Mother's cousin has breast cancer, diagnosed at age 30, and who's at her fourth year of treatment. This is her mammography showing a outer quadrant 2.2 centimeters malignant lesion with irregular borders at her left breast. No pathological lymph nodes were seen at both mammography and ultrasound. The MRI scan showed the lower outer quadrant mass of 2.5 centimeter with malignant characteristics and, no pathological lymph nodes were seen at the axilla. Here's the
Next,
mass.
please. Yeah.
Şeyde oldu çok program.
Technical problem. So if I outline this as a hormone receptor positive, CRP2 positive patient, 2 centimeter tumor with negative axilla. So what would you start first, surgery or neoadjuvant therapy, and which regimen? Yeah.
I think we should give the word to our medical oncologists and then the surgeon colleagues. Adnan abi, what would you recommend for this patient? Looks node negative, 2.5 centimeters tumor,
Yeah, 12.
and which is close to the pectoral border, I think, right?
Is there an invasion of pectoral muscle?
No,
Yeah.
I
no.
don't think so.
No.
Would that change anything? I don't think so, would it?
Maybe
Yeah,
look at
we
that.
generally give
Hmm.
neoadjuvant chemotherapy for these patients. If the tumor is more than 2 centimeters, so it is 2.5 centimeters
You would,
and HER2 positive.
definitely.
Yeah, because of that, we recommend neoadjuvant treatment. But if a surgeon makes first surgery, it's not wrong. So
That's not wrong.
yeah.
Professor Rao, I'd like to direct this question to you as well. What's your threshold? Because I know that there's a lot of discussions here on the tumor boards. So would you recommend neoadjuvant chemotherapy?
Yes, unless they cannot go through chemotherapy, the older, really much older person, anything over 2 centimeters, we automatically go ahead with TCHP again, and then reevaluate. When do we not give neoadjuvant therapy? When it's HER2 positive? Anyway, our current standard is if it's less than 5 millimeters, we wouldn't. If it's between 5 and 10 millimeters, we debate. Maybe then you give Taxol and Herceptin, or Taxol, Herceptin, and pertuzumab. Between 1 and 2 centimeters is really tough. If there's lymphovascular invasion, the estrogen receptors are low, patient has young family history, like if you worry, then we would probably consider neoadjuvant therapy, but over 2 centimeters, we would give neoadjuvant therapy.
Okay, so based on the available evidence that from the Catherine trial, we know that there are some T1Cs, but they're so low in ratio. Are we quite confident that we are ready to give neoadjuvant chemotherapy for patients who are 1 centimeters or higher in diameter?
Right.
Are we ready for that? Or would you recommend that?
Well, we tend to prefer neoadjuvant. Let me put it this way. We find any reason to give neoadjuvant therapy if we can, especially if they're over 1 centimeter. But the toughest, the 1 to 2 centimeters is one that gives us the most heartburn. Over 2 centimeters, it's easy. It's neoadjuvant therapy unless something happens, something else comes up.
Okay.
And 0 patients to 3 centimeter. I mean, if you want to de-escalate the toxic therapy, why don't you start first surgery to give 12 weeks?
You're right in that sometimes you worry about it, but most of the time they get some kind of adjuvant therapy anyway. And 1 to 2 centimeters, if the lymph node is negative, if it's 1.1 centimeter, if you worry about complications, then yes, we would probably go for surgery first. Less than 1 centimeter, we have a debate about it, but often we might go not TCHP or AC, but we go with THP. But this is a systemic disease. When it presents itself at 2 centimeters, you worry about occult metastatic disease. You want to give them neoadjuvant therapy, shrink down the tumor burden, and try and get them to surgery afterwards. I mean, that's kind of the practical way we approach it here.
If you put the table, I mean, this is systemic therapy, no choice, you left the patient. I mean, adjuvant paclitaxel and trastuzumab is a good survival advantage and less toxic therapy. You miss that therapy when you start with neoadjuvant therapy.
True, but at 2 centimeters, that's a big tumor. I mean, HER2 positive 2 centimeters, that would be concerning.
Surgeon's perspective and oncologist perspective different.
Yeah.
just
Yeah.
in the floor?
Also, I ask Bahadur, will you start with the neoadjuvant therapy when we come this patient to you?
Well, as a, as a teammate, I would concur with the medical oncologist most of the time. I don't want to, have a disagreement with them. But I agree with Dr. Rao because we have the, publications saying that over 2 centimeters, we're confident that we start with neoadjuvant chemotherapy in these patients with the anti-HER2 treatments as well. I know that there are some inconsistencies. Definitely, we need a new markers for this range of patients. But for now, our decision should depend on the multidisciplinary, tumor board decisions.
Okay, so on the floor, our medical oncologists, so we have 3 of them. What's your threshold to give neoadjuvant chemotherapy for a patient with node-negative HER2 positive breast cancer? Like 1 centimeter? Is it 1 cell or 1.5 centimeter?
After 1 centimeter, I prefer to give neoadjuvant chemotherapy.
Chemotherapy.
Yeah.
Okay, Melta, what's your opinion?
I think complete response is the main point here. If we can have a complete response, we'll have a survival advantage. So after 1.5 centimeters, I would prefer to give an adjuvant treatment. Between 1 and 1.5, it may be discussed, but 2 centimeters, about 2 centimeters, even though lymph nodes are negative, I should prefer chemo.
Okay. So Taner, would you have an MRI scan? Would you be more comfortable with an MRI scan to, have a very reliable estimate of the tumor size when considering a patient for neoadjuvant chemotherapy?
It's a hard question. I might not know the response. Yes, usually I trust to MRI results with the surgeon examination.
And it's your threshold is how many centimeters?
It's a big dilemma. The easy part, if the tumor size more than 2 centimeters, neoadjuvant, but sometimes we give, if the tumor more than 15 millimeter, give neoadjuvant therapy.
Okay, so it's 15 millimeters. Okay, thank you.
Okay. I'm disagree, but okay.
Dr. Müslümanov, actually, you're right on, if you look at the APT trial, attempt trial, the adjuvant HER2 positive trials, it's 3 centimeters with node negative, and they have great disease-free survivals. That's the trial research version of it. But in the real life, I think T1C is the cutoff. And we should be very careful on staging the axilla in T1C because the patients who underwent surgery, who were diagnosed as clinically N0, about 25% of them have actually axillary disease detected during surgery. So axillary staging is crucial in T1C patients. And other risk factors should also be judged if you're planning to go with upfront surgery. Usually T1C is the threshold here at MGH also.
Thank you.
Thank you.
Oh, there was someone who would like to, yes, please.
Mikrofonu verebilir miyiz arkadaşlar?
Mikrofonu arkadaş.
I ask to the oncologist, does being triple positive or HER2 enriched change your opinion? With
You
the same size, triple positive or only HER2 enriched?
ERPR negative.
More responsive to be.
Responsive.
So no change. I mean, their mind is
Now,
working different.
in hormone receptor negative patients, we sometimes give neoadjuvant chemotherapy after 1 centimeter. We discuss with the surgeon and we give after 1 centimeter. But if hormone receptor positive, we generally give after 2 centimeters.
Now give most of, yes.
Complete response for ER positive HER2.
Less than hormone receptor negative patients.
It's still 50%. I mean, Dr. Rao, would you comment on the receptor positivity as a criteria to lower the threshold for neoadjuvant chemotherapy? I mean, would you
Increase the threshold and give it.
for hormone responsive patients and, you know,
Yes. If they're receptor negative, I'd be more inclined to give it even if they're smaller tumors. Yes, if it's ERPR negative, then 1 centimeter would be, yes, I would be worried.
so these are the patients that do fairly worse in the APT trial. So this is why we send them over to neoadjuvant chemotherapy. Yes.
Is it time to finish? What do you think? We have patient, but actually we passed one hour more.
Let's finish this.
Yeah, you can finish this case and then we will finish.
This patient biopsy came as invasive carcinoma, grade 2, with estrogen 90%, progesterone 10%, HER2 triple positive, and Ki67 as 25%. We already discussed.
This, yeah.
We performed the left breast conserving surgery with sentinel lymph node biopsy. The pathology came back as 2.2 centimeter of invasive ductal carcinoma, grade 2, that doesn't show lymphovascular invasion. Surgical margins were negative, and the sentinel lymph node biopsy came back as null in 2 lymph nodes. So it was a pathological T2 and null staging. And the final receptors came back as estrogen 80%, progesterone 10%, and HER2 triple positive, and Ki67 as 40%. And what should we do with adjuvant treatment?
So this is another medical oncology question. Now we have a T2 and 0 tumor. Would anyone be comfortable with the APT regimen? First, Arflor.
Now, in this patient, as hormone receptors are positive, and tumor is near 2 centimeters, I generally give in postmenopausal patients 12 weeks paclitaxel with trastuzumab in these patients. But if hormone receptors are negative in these patients, then I give generally complete treatment.
Even though it's greater than 2 centimeters?
Yes.
Is that so? Okay. Taner, what's your recommendation?
Actually, I agree with Adnan. Usually, but in clinical practice, daily clinical practice, I give if the tumor size more than 2 centimeters, 6 cycle or TCH like TCP.
TCP, like the BCRG regimen?
TCH like regimen. If the tumor size up to 2 centimeters, usually give like APT regimen or 4 TC and Herceptin up to 1 year.
Okay, so that's what I'm inclined for. And Dr. Rao, what about your opinion on this patient for an adjuvant treatment?
I still would go with TCHP as my first choice for 6 cycles. If I feel that the patient cannot tolerate it, or I'm concerned, then I would go Taxotere and Cytoxan for 4 cycles with Herceptin. And if I can get pertuzumab approved, and then give her an extended period of aromatase inhibitor therapy, and look into the question of zoledronic acid for 6 doses. If I cannot get pertuzumab, then I will look at neratinib for 1 year. The low PR rate is a little worrisome. Those tend to be a little more aggressive cancers. So I would give either TCHP or TCHP with Cytoxan for either one of those.
Right. What about zoledronic acid? Do you generally prefer to administer zoledronic acid right at the beginning of the endocrine therapy, or would you like to defer the treatment until you see the T-score less than 2?
Well, I do definitely get a baseline bone density, and I will wait and see what happens. But I will talk to them about it, because many of our patients do end up having osteopenia at this point in their life. So I would be concerned.
Yes.
Okay, do we have, maybe we have 2 more cases, but I think it's time for finish. Is everybody okay?
It's 8:30.
Olga, what is your situation?
So live, it's more early.
I'm enjoying every minute of it. Great discussions.
How about Rao? Are you enjoying, or would you like to go back to work?
I will have to leave at 12:30 because I have a patient at 12:30.
Okay, okay. Now we can go to home, time to go home, finish our webinar discussions. We'd like to thank you, Dr. Rao and Dr. Tolga. We'd like to also thank our colleagues. Everybody have a good evening and good night. Yeşim, take goodbye.
Yes, thank you very much for
Thank you
discussing.
very much.
It was very, we enjoyed this session, and thank you very much for attending and joining us tonight. Of course, tonight for us, but I see it's time for you. Thank you very much, and all the attendants here and all our panelists. It was a great discussion.
I would like to thank also your opinions together.
Bye bye.
Thank you. Bye bye.
Thank you. Teşekkür Tolga. Hoşça kal. Bye bye.
Sizlere
Bye
de
bye.
ediyoruz arkadaşlar. Umarım faydalı olmuştur. Çok teşekkür ederiz.
Sağ olun.